This is Blood and Cancer, the official podcast of MDedge Hematology-Oncology. I am the voice of MDedge Podcasts, Nick Andrews, and I'm sitting here in this meeting room at this mega complex in Orlando, Florida, with Dr. David Henry, and Dr. Henry and I have probably walked, I would say, tens of thousands of steps in a few days.
Easily. I don't have to walk anywhere when I get home. I've done all my steps for 2 weeks right here.
Yeah, it's unbelievable. I'm trying not to sweat as I lug all of my recording equipment around, but it's totally worth it because I ate 2 desserts at our hematology-oncology board meeting. So I want to talk to you about, first I want to start with just a year in review. We're not quite at a year of blood and cancer at the calendar year. We started 4 weeks into 2019. I believe it was like the last day of January, the 30th or the 31st. How do you feel 1 year into this?
I think it's been a really great experience for me. Doing a podcast, as you and I know, we try and find interesting thought leaders to talk about their particular area of expertise and to make it interesting and relevant and understandable by a practicing audience of clinicians, whether it be doctors, nurses, or whatever, doing hematology and oncology. And we've had a diverse range of topics, anywhere from high science to very practical side effect of drugs. And we're going to talk in a second about new approvals, which was a great way to end the year because we're almost killing the national budget. I hope not, because we have so many approvals in 2018. Turned out 2019 is similar.
So yeah, it's and let's get into it right now. So we've got a part 1 of a 2-part episode coming up. If we can talk for a moment about the amount of approvals that appear to be coming shortly. What happened in 2019? And you talked to a guest who knows all about that.
Yeah, so a colleague of mine at Pennsylvania Hospital in Philadelphia, David Mintzer, did a piece for us on our MDedge.com/hematology-oncology electronic webpage, where you can find all of our podcasts archived with show notes on each one by our residents there at Pennsylvania Hospital who do bullet points very nicely with references. And so he did a piece online, along with Emily Breyer, last year, 2018, of drug approvals, naming the drug, its brand name, its generic name, its indication, its side effects, and its positive effects. And so he said, gee, let's not wait till 2020 to do 2019. So about a month ago, I sat down with him to review 2019 thus far. And so that's going to be online, and you're going to hear his interview shortly, reviewing those drugs in benign and malignant hematology and oncology, of which there are some 11 or 12 now already.
And don't forget, coming up later, Dr. Ilana Yurkiewicz is here with Clinical Correlation, talking about language from the American Society of Hematology. Okay, let's get into it. New drug approvals from 2019 coming up.
Welcome to this podcast. You are listening to Blood and Cancer. I'm Dr. David Henry, and editor of the online electronic journal, MDedge.com/hematology-oncology. And each week we bring you another episode of this podcast called Blood and Cancer, where you can download for wherever you get your podcasts, iTunes, etc. And so today I'm delighted to be talking to my associate, who lives 2 doors down the hallway from me at Pennsylvania Hospital, Dr. David Mintzer, who is our section chief here at Pennsylvania Hospital and a professor of medicine and hematologist-oncologist. Dave, welcome to the podcast.
Thanks for the invitation, Dave.
Well, what we did last year with Dr. Mintzer was to do online, on the online journal, something called FDA Approvals of 2018, and it was a really wonderful thing you did about the new drug approvals, what their names were. They all have very strange names. They have to have X or Y or Z in them, apparently. And then their generic name, their indication, their side effect, and some of their uses in that particular cancer. So it was so popular that we thought we'd do a little sooner this year because our field is so popular and brings out so many new labeled indications. So here we are in late 2019, and Dave is going to go through 7 of what he thought were some of the more interesting new approvals. In a follow-on podcast, we're going to do old approvals with new indications, but today it's just going to be, we'll click through these 7 that are so far in 2019 that are new. So take it away. What would you like to talk about first?
So I thought the first drug I would mention is fedratinib, which is a new JAK2 inhibitor that was recently approved for myelofibrosis. I think we're all pretty accustomed to dealing with ruxolitinib that's been available for many years, which we know decreases constitutional symptoms in patients with myelofibrosis and reduces spleen size and can be utilized in primary myelofibrosis or in secondary post-polycythemic thrombocytosis. Fedratinib was recently approved for similar indication, So this is a new JAK2 inhibitor. There have been many that have been looked at over the past few years, but this is the first one after ruxolitinib to actually come to marketing. So there was a recent couple of trials called the Jakarta trials that looked at utilization of this new drug versus placebo and showed a significant benefit for patients with reduction in spleen volume. Interestingly, they looked at this in a population of patients that were previously untreated, but there was also a second Jakarta study that looked at patients who were either refractory or resistant to ruxolitinib, and they also saw activity in that group of patients. So this is another option. Our listeners should be aware that there is a black box warning that there were some cases of fatal encephalopathy related to what seemed to be a Wernicke's type syndrome, so you should get a baseline thiamine level and monitor thiamine levels in patients treated for this with this drug.
Would this replace the ruxolitinib? Would you use this first? Is it labeled for afterwards? When would you fold it in?
So I don't think we know yet, as is often the case with newer drugs. This may have more toxicity, so I think till we have more experience or head-to-head trials, I would presume we'd still be using ruxolitinib as first-line therapy, but we'll wait for more new JAK2 inhibitors to come out and get more experience with this one and see.
Sounds good. Next.
So another drug, and by the way, I should comment that there's so many drugs coming out, it really is almost unbelievable. When you and I started in this field, and we've been working together for about 20 years, you got a new drug about every 2 or 3 years. Now we get a new drug about every month, and it's difficult to keep up, which is why we started in our group to try to put together this little symposium to kind of learn all the new drugs as they come out. So, and we not only have so many new drugs, each disease is now subdivided, so we have to become facile with each of these drugs and then learn how to sequence them and combine them. So things do keep improving at an incredible level. I won't tell our listeners that you and I are old enough to remember when taxanes first came out, but we are.
And before that?
Yeah. Well, platinum was already out when I finished training. I don't know about you.
Yes.
So the next drugs are the NTRK inhibitors. So as probably most of our listeners are aware, there's a new drug called entrectinib, which targets patients who have NTRK translocations. These are very rare translocations that are seen. They're only present in about 1% of cancers, can be in a common cancer, but also some relatively rare histologic subtypes. There are actually 2 of these drugs now on the market. Entrectinib is the second drug. Last year, larotrectinib came out. And these drugs target this NTRK gene fusion that's present in this wide array of malignancies.
So it can be any cancer.
It can be almost any cancer, right, that's been reported. The difference with entrectinib is that it's also FDA approved for ROS1 positive non-small cell lung cancer, so it distinguishes itself there from larotrectinib. And these, like a lot of our targeted therapies, do seem to have a very high response rate, well over 50%, and these drugs seem to have a very low toxicity level. So you have to look at your fusion transcript panel and see if you can find these, but if you find one of these very rare mutations, this seems to be an opportune class of drug to utilize.
Next.
So next up, a little bit more common than that would be prostate cancer. And this year we have the approval of a third, second-line anti-androgen drug. So darolutamide is now FDA approved. Of course, we're all familiar with the original first-line anti-androgens that we had, like flutamide and nalutamide and bicalutamide. And then after that, we had the development of enzalutamide that we've been using for many years now, and now apalutamide is also approved. Well, this year, darolutamide was FDA approved in patients with non-metastatic castrate-resistant prostate cancer. Like the other more advanced anti-androgens, this seems to be a very active drug with very low toxicity. This was a large trial that looked at the median metastasis-free survival in patients who received darolutamide in comparison to placebo. And in this subset of patients, the median metastasis-free survival was 40 months versus 18 months in patients who received placebo. Again, this is the patients with non-metastatic castrate-resistant prostate cancer.
So maybe the biochemical failure types.
Right, so these are patients who failed just anti-androgen therapy. So there's a variety of studies that have been done in various patient populations: metastatic castrate-resistant, metastatic castrate-sensitive, non-metastatic castrate-resistant, and non-metastatic castrate sensitive. These drugs are probably all active in all of these, but the trials look at these individual subsets. Whether this is going to replace enzalutamide or apalutamide, I think is unclear. There may be some biochemical differences. There might be a hint that there's less CNS penetration and less CNS toxicity compared to other anti-androgens, but certainly another drug that's available and active and relatively well tolerated for the prostate population.
Interesting. Okay.
Next up, we have polatuzumab vedotin. This is a drug that was recently FDA approved for use in relapsed or refractory diffuse large cell lymphoma. So while we cure the majority of patients with large cell lymphoma, we certainly don't cure all of them. Polatuzumab vedotin is a CD79B targeted antibody drug conjugate. We're all familiar with these immunoconjugates and drugs like its brentuximab vedotin using the same toxic moiety, the MMAE moiety. In this case, again, conjugated with the anti-CD79. In this particular trial, patients with relapsed or refractory large cell lymphoma were randomized to see bendamustine and rituxan or any other CD20 antibody, such as obinutuzumab, with or without utilizing the polatuzumab vedotin on an every 3-week schedule. And this trial was a positive trial, leading to the approval. The complete response rate was 40% in patients who received the polatuzumab vedotin added into the bendamustine anti-CD20 versus, in this particular randomized trial, patients who received the polatuzumab vedotin in combination with bendamustine and rituxan had an objective response rate of 62% versus 25% in the patients who received the control arm bendamustine, rituxan, or other CD20 antibody alone.
And relapse refractory, so that's pretty impressive.
You're right. That's another addition to the armamentarium for those patients who are not going for transplant or CAR T therapy.
Okay.
Next up would be the use of erdafitinib in locally advanced or metastatic urothelial carcinoma, so a somewhat less common tumor for us to see, but there are many urothelial tumors out there. This is a drug that targets specifically the subset of patients with urothelial carcinomas who have a fibroblast growth factor receptor mutation. These are present in a minority of patients, 20 or 30% of advanced urothelial cancers, a little bit higher probably in the upper tract urothelial cancers than in bladder. And this drug was FDA approved because of a trial that showed a response rate to erdafitinib in that subset of patients with FGFR mutations of about 40% with a median progression-free survival of about 5.5 months. So again, another active agent to add on top of immunotherapy and standard chemotherapy with gemcitabine or taxane and platinum-based regimens for that subset of patients.
Very small. How big or small a subset of patients is it? It's like 10% of patients?
About 20% of patients with urothelial cancers in general.
Okay, that's not that small.
Again, moving to another more common cancer, that would be the use of alpelisib, a PIK3CA targeted therapy, a tyrosine kinase inhibitor for the subset of hormone receptor positive breast cancers that have a PIK3CA mutation. So we've developed a number of agents that can help improve our response and durability to hormonal therapy. So obviously we're all quite familiar with the CDK4/6 inhibitors with the use of hormones as well as with everolimus. Well, here's another drug that can be added into hormonal therapy for patients with ER-positive breast cancer. So this is utilized in only that subset of patients with breast cancer who harbor a PIK3CA mutation, which represents about 30% of breast cancer. So we can screen our breast cancers with next-generation sequencing through approved tests for this mutation. In this in this study, patients were randomized to fulvestrant alone, to fulvestrant combined with the alpelisib. The overall response rate in the patients that had the PIK3CA mutated cancer was 26% versus 12% in patients who received fulvestrant alone. There was a significant amount of hyperglycemia. These patients can become frankly diabetic, so glucose monitoring is required in these patients. There's some diarrhea, but...
And that's rapid. I think that's even with the day of infusion. You can get the high sugar. So I'm picturing you have a postmenopausal metastatic patient, you put on an AI, a CDK4/6, you then would go, if this mutation is present, next to fulvestrant with this drug?
Yes, I think that's very reasonable. You might also combine fulvestrant with everolimus, but this looks like a new option that might also be available. And I'm sure they'll be looking for new indications besides just combining it with fulvestrant.
Okay, finally.
And last but not least, at least in the drugs we'll cover today, is selinexor, which is a new drug that's approved in combination for multiple myeloma. So selinexor is a selective inhibitor of nuclear export compound that blocks exportin 1. And this drug has activity in combination with dexamethasone. This was, again, a relatively small trial in patients with very advanced myeloma who were so-called triple refractory, that is, they'd received IMiDs as well as proteasome inhibitors as well as darolutamide. This was a study of 122 patients, and there was a partial response rate observed in 26% of patients. The median duration of response was maybe a little disappointing at only 4.4 months, but it's a new class of agents, novel for our myeloma cohorts.
I remember seeing this talked about at a meeting maybe a year or so ago, a phenomenal mechanism that fools or re-establishes in the myeloma cell its death pathway. So instead of being mutated and immortal, it shows it how to die in a very refractory population. And it's a pill.
Right, so many of these new agents are oral. It's becoming more difficult, not just to keep up with them, but to develop expertise in utilizing them, and toxicity, as I said, combining and sequencing them. But it's really amazing the strides we're making for our patients going forward.
Incredible. Well, here in a few minutes, we've covered 7 new approvals and their indications. I want to direct our listeners to the online, where Dave Mintzer and our aspiring oncologist resident, Emily Breyer, have actually laid this out for you in tabular form, so you can see all the approvals of 2019, along with discussion of the old drugs with new labeled indications in 2019. So again, you can find that on the webpage at mdedge.com/hematology-oncology. And you've been listening to Blood and Cancer, this podcast coming out weekly. You can review us online if you like. We'd love to hear your thoughts. And Dave, I want to thank you again for doing this. It's a lot of work to prepare this and to prepare what you did online with Emily. So we appreciate it very much.
Thank you very much. Now, let's get back to work, shall we?
Let's go back to work. Agree.
And that concludes the interview portion of our program. Remember, this is part 1 of 2. Part 2 will be available wherever podcasts are found. When we come back, Dr. Ilana Yurkiewicz and clinical correlation. Welcome back to Blood and Cancer. I am Nick Andrews. It's time now for clinical correlation with Dr. Ilana Yurkiewicz from ASH 2019.
I'm Dr. Ilana Yurkiewicz, and this is Clinical Correlation, a segment about the human side of hematology and oncology care. What better place to record a clinical correlation segment than at the American Society of Hematology, or ASH, meeting? For the past few days, I've been in Orlando, Florida, hearing about the latest research in all sorts of blood conditions, malignant and benign, that can ultimately improve things for the patients we serve. So apologies in advance about the quality of this recording, as I left my podcast equipment home in California. And yes, as theoretical and basic science as some of the research is now, the goal is ultimately to bring it to clinic to make things better for our patients. And yet, when we dive deep into the data, it can be strangely easy to overlook this fact. I'd like to use this segment to give a shout out to a document created by Dr. Tatiana Prowell from Johns Hopkins University. This document was created by her, along with staff and other leadership, for ASCO, the upcoming American Society of Clinical Oncology meeting. The summary is that language matters to convey the respect we have for patients. I'd like to read some of it directly. Here are some lessons she imparts. 1. Do not blame patients. Patients do not, quote, fail therapies. Therapies fail patients. 2. Doctors do not manage patients. They manage disease or therapies. 3. Do not use language that implies the patient is the disease, such as 12 diabetics. Rather, say 12 patients with diabetes. These lessons, of course, are universal for all medical conferences. And while we are improving, I did notice some slips at ASH this year. However, because of the work of Dr. Prowell and others, I think we are all more aware of these slips and the importance of using language that puts the patient first. Hematologists and oncologists, of course, respect and value patients, but there is still more we can do to convey that. Speaking deeply about science and conveying respect are not mutually exclusive, but complementary. I'm glad that leaders in academic medicine are making this the priority it deserves to be. Thanks for listening, and I hope you'll tune in next time for Clinical Correlation.
And that concludes this episode of Blood and Cancer. Remember, there are robust show notes available with all of the information discussed in the show. It's time to give credit where credit is due. Blood and Cancer is produced by Mary Ellen Schneider. It's hosted by Dr. David Henry. Clinical Correlation is written, recorded, and produced by Dr. Ilana Yurkiewicz. All MDedge podcasts are produced by executive editors Kathy Scarbeck and Denise Fulton, multimedia editor Terry Rudd. I am your audio engineer, audio editor, and the voice of MDedge Podcasts, Nick Andrews. You're listening to Blood and Cancer.